it. We'll just give it another minute or two here, uh, and then I'll open it up. See the green's out right now. He's thinking about taking down one of those fish.
Oh yeah.
Yeah, he's never out, the big green one. But
Uh-huh.
he's been sized. I did a water change today, and he never comes out when I do that too. He's sizing up one of those fish. They go through these
Boy,
weird things. Here he comes. See him? See him?
yeah, nasty. What if he's
Yeah.
a little hungry? He'll take some. Like, what do you normally feed him?
Yeah, like so I put about a pound and a half of food in the tank
Right.
every 2 or 3 days. It used to be if I didn't do it 3 days, he would take something down. But as he kind of gets bigger and more comfortable,
Sure.
they're an instinctual animal, right? They're not gonna exert force if they know something's coming. Um, yeah, Dr. John said there, small children, right? He's getting to that point. My last one before I went down to the downtown Houston Aquarium was 6 feet. Marcus had lived what, 21 years? I donated a long time. I had it a long time ago. I built a little
22.
custom tank. 22 years. And it was the biggest green eel. It died about 68, 69 pounds, almost 11 feet. So it was really cool. But yeah, if I don't feed them enough, they will they'll take a fish down. The sharks don't do anything. But the eels, oh yeah.
Yeah, a little more aggressive animal for
Yeah,
sure.
yeah, they definitely are. The Georgia, what that one aquarium, they couldn't figure out why their like little 4 and 5 foot sharks kept disappearing. It's the green eel started eating the sharks in the tank. So
That green eel cost you some dough, man. Make you have to replace some of your boys in there.
yeah, it does. But I built
But,
the tank over.
you gotta keep a tough town. So you gotta have a city with some brawlers, some nice guys.
Oh yeah, it's
And some,
survival of the fittest in there. That's for sure.
that's the
That's for
jungle.
sure.
I love that.
All right,
I used to,
everybody. We'll go ahead and I'm gonna go ahead and kick it off. We're at 4 minutes. I usually say we'll give it five, but I got a couple things to say just to kick off tonight's meeting. First and foremost, everybody, thank you so much for your time, your attention. We know all of you are very busy people. You don't have a lot of extra free time, and we appreciate the little free time that you do have. And especially a lot of you are probably in the comfort of your own home. Some of you may be doing charting and stuff still at the office. I hope we make that a little bit more eventful if that's where you are. But we just appreciate the opportunity to be in front of y'all and the opportunity to hopefully affect some change in your practice. So tonight, hosted by the IORE, the Institute of Regenerative Education. Um, if you are not familiar with the IORE, you can go to IORE.com. There's protocols, lecture halls, certificate courses, everything else. And by the way, as of today, just had some payment processor issues. Tomorrow morning, the official retrospective repository nationwide study, so you can be under an FDA accredited HHS serialized experimental application of biologics, but have an FDA accredited IRB oversight is launching tomorrow morning. So be on the lookout for that. If you sign up through the IOR, you'll get an email. It'll be in the Facebook group. But tonight we've got a very special treat. We have Dr. Jason Bell. Dr. Jason Bell is a board member for the outside medical board for the IORE. He's a fantastic podiatrist. He's a fantastic guy, a great family man, and really, he's a shining example of how to win in all aspects of life. And that's why I really like him. He's more than just a doctor who gets on a call to us. And I think that it's great to hear from someone who's winning in all aspects of life. And this is just one facet today. He's going to talk about him and his cash biologics. We're continuing on is this number two or three?
it's two.
This is two. This is
Yeah.
two out of our four series part. So with that, Dr. Bell, if you want to give a quick little introduction, thank you for your time tonight, man. We always appreciate it and look forward to it. We'll do a Q&A at the end because I know you guys love asking Dr. Bell questions. So we'll do that at the end. Make sure you use the Q&A function. I think it's in there. Maybe there's not a Q&A. You can just use the chat. But anyways, I'll get off. Thanks, Dr. Bell.
Sure. So thanks for joining us again. It's my pleasure to be here. I love talking about the stuff. And tonight's talk uh, is about a condition that so many of us see on a daily basis. So obviously it's quite applicable. And I like doing these kind of going back and forth with the use case and some of the science, and then kind of tying into, or like I said, going back and forth to some of the obstacles that I notice my peers face in using biologics in the practices. And I do a lot of peer-to-peer calls, and for some of my colleagues, some of my fellow docs, they're quite comfortable with it. They have a pretty good knowledge and background of biologics, and just want a little bit more detail, maybe want some protocol insight. And then others, are, and I say this with, of course, no disrespect because I get it, but others are apprehensive, maybe even scared sometimes. Some don't fully understand if we can or can't use this. Um, is it being widely used? Are there risk factors? All the fair questions that any doctor should have about doing anything that he or she is not, very comfortable with. So I get a pretty good mixture, but I'd say a little bit more than half are still apprehensive for different reasons. So as I speak about the science tonight, I'll also tie in the practical issues that I face, or that other docs face as well, that I've learned about in doing so. So if I go a little back and forth, I think it'll all make sense to you guys, as it's tied together, and hopefully it's a talk that makes everybody understand things a little bit better, feel a little bit more comfortable, understand that we're all in the same boat, and a lot of us have the same questions. So if there's questions or concerns on one side, on the flip side, there's just as much, if not more, and more, I'm noticing every month or two, enthusiasm about getting into the space, because more and more docs are learning about the benefits of biologics. And I think just as important, the public, although they don't know the detail we know, they're becoming much more open-minded to it. And just the term regenerative medicine is becoming much more widely used and thought of. And this is no longer the big mountain to climb, for you, for all of you to breach the topic with your patients and start to mention it. You're not going to get odd looks. You're not going to be looked at like you're practicing some sort of voodoo medicine. Those days are over, and I really try to push that to the docs when I do my peer-to-peer talks, because I think that's one of the things that doctors sometimes are apprehensive about, is does the patient think this is something kind of too extreme because it's out of pocket? Is it too over the top? And those things are just not the case anymore. And that kind of is my passion, because I want the doctors to get better outcomes, and I want you all to make more money. And our first objective is to help our patients. But if we can do it and make our practices more money, that's a win-win. And there's nothing wrong with that. And every time I do a talk, I can't help but emphasize it, because you can speak the truth out loud. And I know pretty much every doctor watching is frustrated with their reimbursements for most things. And there are other ways to increase your revenue. And in this case, there's a really good moral way to do it. And that in this case, and I'll speak about it throughout tonight's talk, really, in my opinion, a better way to practice medicine in certain instances. So that's the theme of my talk. I'll do a little slideshow as we speak, and we'll go from there. I wanted to go back to like a personal experience first, because it makes this whole talk relatable. Um, when I first started practicing, within the first 5 years or so, um, I was pretty enthusiastic about pushing the envelope, and doing things that I thought were best for my patients. I thought I was well trained. I thought I was a pretty informed young doc, and I very soon to my career, I realized there were some obstacles, and some of them were fair and I understood them, and I thought some were a little ridiculous. Some credentialing at the hospital I operated at, I felt was a little silly and ridiculous. And doing certain cases that I wanted to do. Some of the parameters from the insurance companies I thought were a bit ridiculous. So when you're young, you have that fight in you, and I kind of was into the fight. So I put first up here, it says, the FDA is not our enemy, and I start with that because one of the big things we get with our peer-to-peer talks and just in general is are biologics illegal, or is the FDA saying it's wrong? And that's not the case. It is not illegal to use biologics. It's just the FDA hasn't fully said, given the full open pastures to go ahead and do it. They want more data. Data is good. Data is fair. But the FDA does not inhibit us from practicing medicine, as we like to say with our own group. We are doctors. We are entitled to practice medicine. And just because the FDA hasn't fully approved, quote unquote, the use of biologics, it doesn't mean they are against biologics. So it's a good thing. The FDA is really becoming more and more warm to what's going out there. And just doing this talk tonight, the Institute of Regenerative Education is making great headway. The FDA is actually kind of on our team. We like to say is kind of our friend. So if they're our friend, they're not our enemy. So that's one thing I want to get out there. You don't have to be afraid. And one of the ways to make you all not afraid is the FDA is not against the use of biologics. Back in 2010, I put Obamacare up there because it was somewhat early in my career. And I think a lot of docs had some concerns about what's this Obamacare thing and what's it going to do? And is it going to make things better or worse for us as doctors, better or worse for us as patients? So I decided to get involved. And I don't want to get long-winded with this, but I did get myself involved through some contacts I had. And I was invited to a few symposiums about that were kind of titled Healthcare Policy. It was like a precursor to Obamacare. And after one symposium, I developed a bit of a relationship to some of the organizers. And I got myself invited into like a bit of a private chat with one of the policymakers in Washington, D.C. that was going to be potentially part of the architecture of Obamacare. And ultimately, I got myself invited to a meeting with this policymaker and Catherine Sebelius, who was head of Health and Human Services, a cabinet appointee by President Obama. And in meeting with them, I was a little bit disenfranchised because what they were saying and when these guys gave some talks, these policymakers gave a talk to a large symposium of hundreds of doctors. What they were saying in some of those talks sounded a bit utopian to me, and I didn't really know how applicable some of their thoughts would be. And throughout the large lectures that I attended, the participants could ask questions, and my questions were not contrary. They weren't to be difficult. They were just meant to really be thought-provoking. And I noticed that they didn't really like some of my questions. And this was the Q&A was right before I was supposed to meet with them personally. So we get through the Q&A, and I get to meet with Catherine Sebelius. Again, it was a cabinet member. It's pretty cool to meet with a cabinet member of an administration and this particular policymaker. And what happened between me and that policymaker stuck with me my whole career. And when we got in the closed door meeting, how he was on stage and how he was in this little private meeting was two very different people. He was kind of charming-ish during the big symposium, very much an advocate of access to healthcare, reducing healthcare costs, and all the things that makes sense. But behind closed doors, he was quite cold. Didn't seem to give a crap about meeting with me. It was a small group of other doctors. It wasn't just me. It was a handful of us, and he was just super corporate, and he didn't really want to hear the day-to-day stuff. And I always felt the day-to-day stuff is really what counts. And as we spoke and we got to know each other during this meeting a little bit, he was a vascular surgeon who had quit practicing medicine, I think, pretty early on in his career to go become, a policymaker, so to speak. And I remember thinking to myself, well, I kind of know why he quit, because he doesn't have that it factor. He had no real charm or warmth to him, and he probably wouldn't have done all that well in private practice. And this was a little bit before big hospital systems bought up practices. So it was a little bit more still at the very end of the boutique practice world. And it's like, you don't even see patients. You probably weren't very successful seeing patients because at that time he was only in his early to mid 40s. So he was young. He was already done practicing, going into the bureaucracy side. And his lack of interest in hearing what some docs had to say from a day-to-day basis and our concerns about what some big government system could do were of no interest to him. And he showed no compassion in those meetings. And it kind of led me to my regenerative medicine arena, because regenerative medicine was first becoming, I'll say, popular. It really started with I would say, in my experience, with PRP. And everybody seemed to be a bit apprehensive, but I always felt intuitively the body has a tremendous ability to heal itself. Um, and it does, and that's what we'll get into. Um, so getting back to the FDA and why they're not our enemy is that they just want data. And if we accumulate enough good data and we prove that they're safe, eventually there'll be full passage. But like anything that's still somewhat new, it's right. It's data, data, data. So even though the FDA is a bureaucracy, they are finally being open to doctors providing data and literature in the world of biologics. And that's why I started the talk off by saying the FDA is not our enemy. Um, the the policymakers, I think, can be sometimes in Washington, but we can't be afraid of people who don't practice medicine. We see, we deal with on the ground, so to speak. It's us who are practicing every day, and we see outcomes and we see what works and doesn't work. So with all that said, when I speak to other doctors, the first questions are, some of the first questions are, is it safe? And they sometimes don't sound comfortable. And I'm talking about my peers. So I bring up things like blood transfusions, surgical tissue allografts, skin substitutes. And when I sense that a doc is a little bit apprehensive, if there's a risk factor, I say, and I can either read between the lines or they'll flat out say, what about like disease transmission? And I tell docs all the time, we've been doing blood transfusions and we've been using allograft tissue for surgery, whether it's bone graft or tendon, cadaver tissue for tendon repair, probably since the 1960s, maybe even the 50s. We've been doing blood transfusions probably even before that. So if we've been using allogenic tissue or other people's tissue for 70 years or more, you can only imagine how the safety profile in 2026 is nothing's false, but you can imagine how darn good it is. So when I say that, it's like the eyes kind of get more wide open. It's like, oh yeah, that's true. People get blood every day from another person. We use other tissue from other people for ACL reconstruction, probably by the thousands every day. So a screening process has been in place as far as safety profile for a very, very long time. And then more specifically with podiatrists, and I speak to mostly podiatrists and some orthopedic doctors and some pain management specialists. When I speak to podiatrists, again, when we're in the apprehensive part of the talk, when I sense that, I ask them, do they treat wounds? Do you treat wounds? Of course, almost everyone says yes. And I will always say, do you use skin substitutes? Almost everyone has said yes. And I say, well, so you've been using allogenic tissue your whole career, and you've been laying it on an open wound. The FDA doesn't have a problem with it. It's been billable probably since the late 90s, as far as I know, certainly throughout the 2000s. That's tissue allograft. That's very close to what we're talking about. And you're laying it onto an open wound. So if that's been done by the millions for over 30 years, and there's no legal or safety concerns, then using biologics in this type of application for tonight's purposes, for use of arthritis, should not spook or scare anybody because we've been using allograft tissue for such a long time. And it's especially, I think, enlightening to my podiatry colleagues when they say, oh yeah, skin substitutes, they've been around forever. Well, if you can lay them on a wound, why can you not use them for other conditions that we may see? So that's the safety and comfort level that maybe if there's hurdle one, maybe that's it right there. And I think that's a good way to get over hurdle one. I think I said this in my last talk, so I'll be very brief. And I mentioned it at the beginning. The public is very interested in regenerative medicine. The public has realized more and more that if you take care of the body, it has a tremendous ability to help heal itself. So I write here, med spas, red light therapy, intermittent fasting, cold plunge, lasers, hyperbaric oxygen, anti-inflammatory diets. All these things are means and ways to give the body supplements, to give the body energy to help repair itself. The public, when I say the public wants it, I mean, this is everywhere. This is all over your Facebook pages. This is all over podcasts. This is the new wave of medicine. There's almost an anti-pharmaceutical mantra out there, which I almost think is a little bit unfair, but medicines and drugs do certainly have their place still. But there is really a swing to the other direction. So not only do we not need to be afraid, our patients are not afraid. And I think that's real important for everybody to keep in mind. Um, Insurers don't pay. And I write, who cares? And I'll tie this back to what I started the talk off with. I couldn't mean that more directly. I don't care the insurers don't pay. Our job is to get our patients better. Our job is to use our knowledge and experience to get our patients better. And furthermore, our job is to practice the highest possible standard of care. I do not care if an insurance doesn't pay me to offer a biologic. If a patient of mine has arthritis and I think this is their best option, I am certainly going to mention it. I'm certainly going to inform my patient. And if they're interested, I do it. And I've been doing it for years with great results. So the insurers not paying for it is nothing to fear. And even more so, it should not get in your way of providing the highest standard of care. And I will make a strong argument in a moment that much of what we do, and I include myself because I've done these things for most of my career until recent years, I would argue is less than the standard of care, at least what I have learned about standard of care and what I have seen in my practice. And, redundancy in life is everything. Anything you do over and over again, you'll become good at. It's not the smartest person in the room who becomes successful in whatever venture they're doing. It's the person in the room that puts the maximum effort into what they're doing. So if you're a conscientious doctor and you're seeing 20, 25 patients a day after day, year after year, you have learned a lot. You have seen what works. You have seen what does not work. So you as doctors, we as doctors, we can practice medicine, especially as we become more experienced. And I do not care that the insurances do not recognize it. They will not dictate me from offering my patient their best options. So I think, and that's another obstacle that I see, and it gets back to those policymakers. I don't care if it's policymakers in Washington, D.C. I don't care if it's policymakers within a large commercial insurer. They don't practice medicine, and frankly, they know nothing compared to us. So these are very broad scoped thinkers. They have their role, of course, but we're there on the ground. We're seeing it every day, and them not paying for something doesn't mean that something is not highly valuable. And I have certainly learned that through biologics, and I would say that might be the largest obstacle that I hear from my peers when I do my talks, peer-to-peer talks with other docs. That seems to spook other doctors, and it really shouldn't. So back to what we're here for. When I first started using biologics several years ago, I started with PRP and I moved along to allogeneic tissue for reasons I'll get into. I kind of did my own I guess I developed my own self protocol that really made me go through the conservative care paradigm. And because we've been taught that, and that's still applicable and fair, especially if you're talking about surgery. I certainly believe, and we should go through conservative treatment options before we do surgical intervention when it's the appropriate thing to do, which is quite often, especially in podiatry, when much of what we do is elective. A lot of our surgical procedures are elective, so thus going through conservative care makes perfect sense. And that's how I approach biologics in the beginning, because in the beginning, people tend to be a little bit more apprehensive. As the years have gone by and my results have been awesome, I no longer make my patients start on NSAIDs. I no longer make my patients get a steroid shot. I no longer make my patients go to physical therapy. I give my patients options. It goes back, decades and decades, oral NSAIDs. It's a non-starter for me. I don't even really mention them. I'm not going to put somebody on NSAIDs anymore for arthritis. It's obviously short-term relief. It's not addressing the condition whatsoever. It doesn't produce more cartilage. And most importantly, of course, there are side effects. I tell patients all the time, if it comes up, if they ask, if you need an NSAID, if you're taking Advil 3 or 4 days a month, no problem. You're good, more than likely. But if you find yourself needing to take Advil, Motrin relief 4 or 5 times a week, week after week after week, month after month, you are doing your body a big disservice. And I talk about, it's rough on the kidneys. I talk about this, the leading cause of gastric ulcers. If it affects the kidneys, it can affect your blood pressure. And how many of our patients 45, 50 plus have reflux disease? Or how many of our patients 45, 50 plus have hypertension? Are you helping your patients by putting them on an NSAID for the next 3 years? In my opinion, no. I think you're doing them a disservice. So oral NSAIDs are out. And if it comes up, which it rarely does, most of my patients understand that almost immediately. But if it comes up, I'll say to them I like to give examples to illustrate things. I'll say, if you take Advil every day for your ankle pain, for your ankle arthritis, does it feel better? Yes. If you stop taking Advil, does it start to hurt again? Yes. Well, then that means you're doing nothing for your problem, and it's doing nothing for your problem because the day or 2 days after you stop taking it, you're back to square one. And that's an easy thing to understand, a child to understand that. So NSAIDs, to me, antiquated, and I think, in my opinion, a poor standard of care unless they're infrequently used. Oral steroids, again, pretty much for me, a non-starter, maybe for an acute inflammatory condition, something like gout, not a problem. But oral steroids, obviously, for any arthritic condition, that's generally a long-term problem. You don't want to stick someone on prednisone indefinitely. I mean, that's nuts. Let's talk about the same things with NSAIDs. You can increase blood pressure, but even more than that, they're immunosuppressive. They can push somebody into osteopenia or osteoporosis. Again, how many of our patients have reflux disease? How many of our patients have hypertension? How many patients, especially our female patients, are losing bone density by their 40s or 50s? So oral steroids, I would think and hope, are pretty antiquated. Injectables, probably the mainstay of most of our practices. I'm not an opponent of that. I still do them when applicable, but I'm moving away as much as I can because I go back to standard of care. Is an injectable steroid a high standard of care? Well, I would say that depends. If a patient gets, and I say this to patients all the time, some of what I'll speak about is what I use to talk to patients. And I think these are phrases that make people understand and get to where they are very interested in using a biologic. Steroids are catabolic. They break down tissue. So I will tell patients routinely on a first visit, I'll try to bring a biologic on a first visit when it comes to arthritis because I think it's appropriate. But also bring up an injectable steroid. And I will say, look, the steroid is not really addressing your problem at all. It's just suppressing the inflammation for a difficult period to define. If you're one of those patients who gets 12, 15, 18 months relief from an injectable steroid, pretty good medicine. I can live with that. Pop in here every 15 months, maybe I'll give you another steroid shot. I can't say that I have a big problem with that, and that's not poor practice. But if you get 3 or 4 months relief and you come back to me in 4 months from today and you say, Doc, that shot you gave me 4 months ago was great. Felt great for the past 2.5, 3 months. But last month, it's really been bothering me. That's why I called your office to come back. So I say, okay, so you had 3 months relief. It's really not appropriate for me to give you another steroid shot. And again, I get back into steroids are catabolic. All I'm going to ultimately do is make your condition worse and increase the odds of you needing a joint fusion or a joint replacement sooner rather than later. So, and if I've introduced biologics in the first visit, I'll revisit it and say, which I'll get into in this talk in a moment, we have a better tool. Now, this is in my opinion. And the data, there's lots of data that we have to give to you guys that would illustrate this. I'm practicing for 23 years. I have a lot of my own data, and I treat patients every day, and I see and know what works. And biologics work very well, and they don't have side effects, and they're not catabolic. So in that moment, a higher standard of care, in my medical opinion, is a biologic for an arthritic joint rather, excuse me, than a steroid. So I explain to my patients, we can help your body help itself. We can supplement this joint, and hopefully your body responds in the way it should, that you will have an innate secondary response, and we'll get into that in a minute, where not only are we going to reduce your inflammation, and thus you'll feel better, you'll have less pain, we're going to make a healthier environment in that joint. And then your body can go through a differentiation process to supplement that cartilage you have left with what it needs, with what it's lost. And that's collagen, hyaluronic acid, and so forth. So we'll get into that. So I like to bring it up at a first visit because I think patients deserve to be informed. And what I typically say is we finally have a really cool option, because I say historically we stuck our patients on NSAIDs or oral steroids. I will, in 30 seconds, if not less, tell them the downsides. I'll go through the steroids like we just talked about, and I'll say it's not really a long-term thing unless you're really getting extended relief per injection. And I just say it with enthusiasm. I say it's really great that we have a newer option that is better than all the other options, in my opinion, in my experience, treating patients the last 23 years. And then, of course, when appropriate, there's surgery. We as podiatrists, most of us, a lot of us, are surgeons. I've done countless fusions, countless replacements. And if I'm catching a patient severe arthritis or end-stage arthritis, I'm not going to mention a biologic. If I put up an x-ray and the joint space is almost gone, or it's probably a surgical conversation. Of course, I'll still mention conservative care for temporary relief, but there's a place for everything. And end-stage arthritis in our world is usually going to result into surgery. And this is another thing that I find resonates really, really well with our patients, to get them to understand how and why biologics is a great choice. I explained to them that arthritis is not an injury. And I may have done this in my last talk. I'll literally, in my stool, like I'm sitting now in my office, I'll literally turn around and I'll pretend to punch the wall. And I say, if I punch this wall right now and I break my hand, there's an acute process because of injury. There's chemotaxis or cell mediators that are going to draw the cells that are involved in the proliferation of healing to the injury site. The body has a very good ability to, quote unquote, heal itself during an acute process. And I point to them and I say, but you did not injure your ankle. You've had arthritis. You've been complaining. You just told me off and on for the last few years, and it's getting worse. That's why you're here. We did an x-ray. We saw joint space narrowing. You have arthritis. This is a condition. This is not an injury. So a condition, I say this and it resonates, your body's doing nothing. It's just there. It's inflamed. It's aggravated. There's no inherent healing response. It's just kind of sitting there dormant. And I'll sometimes even get back to that's why NSAIDs and steroids don't do anything to change that. So your body's kind of hanging out doing nothing. And we've kind of just looked for some relief by taking Advil, all day long, or getting 4 or 5 steroid shots a year. But we're really not addressing the cartilage. And that's the definition of arthritis, loss of cartilage. So when I tell them this is not an injury, this is a condition, your body is not doing anything, it makes sense to them. Just like it makes sense to them when I pretend to punch the wall and say, if I break my hand, as long as I immobilize it, I will heal nicely, because there's an acute process. There's proliferation of cells that come on in and help heal the soft tissue injury. So no chemotaxis during arthritis. There's no proliferation of differentiated mesenchymal stem cells. And that's where you get into biologics. The benefit of biologics is to apply what the body wants or needs to an area of pathology to help the body heal itself. That's how I explain it. This is a supplement to help the body treat itself. This directly is not healing you. Okay, we have to stay away from that, because it's not. It's creating an environment for the body to do its own magic. It's fuel. It's giving the body what it needs. It's giving the body what's laying dormant. We're going to give the body some stuff to go through a process to get a little bit better, and we'll talk about that. So what became big in the world of regenerative medicine, and it's been over 10 years, probably 15 or so, was PRP, probably the biggest. Autologous differentiated mesenchymal stem cells. And it's funny, because when I do my peer-to-peers, most docs I talk to either have done that or certainly know many colleagues that do autologous differentiated mesenchymal stem cells. They don't say that word, but they know PRP. And there's this false sense of comfort with PRP. They think it's quote unquote legal and safe and fine, whether they do it or they don't. They've heard about it, so PRP is cool. Maybe I'm thinking about getting a PRP, but I wanted to talk to you about it first. So one of the first things I would tell that doctor is, just because it's autologous, it does not change anything. Autologous differentiated mesenchymal stem cells are not FDA approved. It's the same boat as allogeneic tissue. So I think there's safety in numbers and in years. So because a lot of docs do it, and there's a high number and many years of docs doing it, everyone thinks PRP is fine, PRP is fine. It's not fine. But what gets a lot of doctors over the hump is when I get into the benefits of allogenic tissue, I say, if you think PRP is fine, if you've never been scared of that, or if you know other doctors that have been doing it for years and they're not going to jail, they're consenting properly, and they're using it in their practices, there should be no reason for you not to consider allogenic tissue because it's the same thing. And that is a pretty big stumbling block for a lot of doctors. That when I say that, again, they're that refreshing, like, oh wow, I can do that. Well, I can go in this direction. PRP's been around forever. Dr. Bell is telling me it's the same thing. One's just autologous, the other's allogenic. That's the only difference. The FDA sees it no differently. And I think it's really important for everyone to understand, whether it's the PRP or BMAC or any of the other autologous means to get your differentiated mesenchymal stem cells, allogenic derived mesenchymal stem cells are absolutely no different from the FDA's point of view than autologous. The difference are the results. So I started with PRP. Like I mentioned earlier, I was a big fan intuitively of regenerative medicine. And I did PRP for probably 4 or 5 years, starting about 8 or 9 years ago, and had decent results. Not great, but decent. And here I'll get into how and why the results were only decent. Intuitively, after like the first year or so, I started to think to myself, especially was anybody in my mind at this time, 50 plus, what am I really giving this guy, or what am I really giving this woman back? What concentration of growth factors or collagen does a 57-year-old have that I'm taking from his blood, centrifusion, and then reapplying it back into that arthritic joint? My instincts, without really any detailed knowledge, said probably not much. And maybe my instincts were giving it some thought as my results in patients aged, say, 40 plus, weren't terribly impressive. So that's what made me start doing the deep dive into allogenic tissue and ultimately led me to becoming a user of Wharton's jelly almost on a daily basis. So some facts about PRP, what we've learned about PRP. So it can upregulate the inflammatory mediators. The last thing you want in an inherent healing environment is the inflammatory process. That's the very thing that suppresses collagen generating proteins. Arthritis is literally defined as a cartilage-based defect. It lacks type 1, 2, and 3 collagen, most notably type 2 collagen, and it's lacking hyaluronic acid. That's why the cartilage is suffering. What the body can do to change that can't be done in an unhealthy environment, in a chronically inflamed environment. So PRP does not reduce inflammation. And in many cases, it can spike, especially the older someone gets. And I would get them here and there. I would get patients calling me the first 3 or 4 days post PRP, having a spike in inflammation and having a spike sometimes in edema, visual edema. You're not giving them, in many cases, what they need. And the other thing that started to make some sense to me is I couldn't prove either way. And I write here, unreliable metrics. Everybody's different. Now, I started to learn more and more. My 55-year-old tennis player with subpterygium arthritis, I'm not giving him anything back. But even my 40-year-old runner who has ankle arthritis or first MP joint arthritis, I don't know what he really has. We're not really measuring what we give. We just have some company come into our office, helping us take out, 30 cc's of blood or whatever it was. They spin it. They give us back a little shot glass worth. We put it into our syringe and in it goes. Are there really any metrics there? No. So what I'm getting back from one 35-year-old, I don't know if the 35-year-old the next week has the same amount of growth factors and such. So unreliable metrics, again, was becoming a concern. This is a cost to our patients. Of course, it's not covered by insurance either. And I should know what the heck they're getting. And I started getting a little more uncomfortable as time went by that I didn't really know. Where I'll get into it, umbilical cord tissue is much more definable. It's much more scientific. And umbilical tissue doesn't differ person to person or fetus to fetus as people do. A 35-year-old who takes no meds and doesn't drink alcohol or smoke cigarettes may have a lot different types of collagen and growth factors in his or her bloodstream that we can take than an obese 35-year-old or a 35-year-old who doesn't eat properly and so forth. So even the younger patients aren't terribly predictable. So I wasn't comfortable with undefined metrics. And then finally, extra steps. When I started to read and learn about allograft tissue and specifically mesenchymal stem cells from Wharton's jelly, the very thought of not having to draw blood was extremely appealing. For anyone that's done PRP, of course, that's sometimes a headache. You have tough sticks. You have people that become faint or actually faint. So just skipping that step, I thought to myself, if I even get equal results from this allogenic derived tissue, I'm going this way because I would love not to draw blood anymore. So Wharton's jelly, it's an anatomic region of the umbilical cord. And the benefit of Wharton's jelly is it's predictable and it's loaded with mesenchymal stem cells, types 1, 2, 3 collagen, hyaluronic acid, and extracellular matrix. When you apply that to an arthritic joint, here's what happens, and here's the good news, and here's what produces results. You down-regulate inflammation. So the opposite of PRP, we're reducing inflammation, so we're creating a healthier environment. It seems to be the key. Once you create a healthier environment, once the tissue is no longer so inflamed, the body now has the opportunity, because of a healthier environment, to allow for what we refer to as collageneic differentiation. And that's the body's ability to produce collagen-based building blocks that the body needs to help repair itself. So as I write here, you fuel the arthritic joint with the biologic and you supplement the cartilage-based defects to help the body help itself. And when you provide that inflamed joint with a Wharton's jelly and you downregulate inflammation, which you will, that's the beauty of it, because loads and loads of hyaluronic acid, which you're getting, and extracellular matrix and the collagen that you get, that will do the very thing that the body needs to get better. It's calming down a storm so the body can then help itself. So the very opposite, let's say, of a steroid shot. You are not helping the body help itself with a steroid shot. But when you load a joint with hyaluronic acid and ECM and collagen, you create a differentiation process where cells can be made from one's own body to come into that affected joint and supplement that joint to get it feeling better and to make it healthier. And the proof's been in the pudding. Results speak for themselves, and we have lots of data to show that. So that is the real key to allogenic tissue, is you are decreasing an inflammatory environment so the body can differentiate and go through collageneic differentiation to then therefore go through an inherent process to repair the tissue on its own. We're just giving it the energy on its own to give it back what it's lost. And I have patients in the hundreds now. We have very good data with my office in the hundreds that, and we have a survey, and the survey will indicate how much better they are pre and post application. And I have hundreds of patients that come in at an 8 or a 9, a 7, 8, or 9, and are at a 1, 2, or 3. And about half of them, and I've been doing this routinely for 3 years, about half, maybe a drop less, are still on number 1 3 years later, and about the other half are on 2 or 3. And I say this and I answer the questions for my patients. I will tell them, I am sure if you get sustained relief and you feel lots better and your motion's improved and you spend $700, $800, whatever it might be, and I don't see you for 15 months, you'll gladly spend it again, especially knowing that you're doing no damage to your joint. You're not dumping steroids in your body. You're not dumping NSAIDs in your body. You're actually doing something that your body wants and needs. And I constantly get the shake in the head. Yes, of course, that makes sense. So that's the basics of it. And any questions, please fire away.
All right, Dr. Bell, let's go ahead and we will fire through the questions. So let me bring it up here. I got my little helper with me too, so. Okay, so our first question is, due to stem cell business, offer only umbilical cord for arthritis, what would be a good explanation to tell a patient why they should go with umbilical cord rather than their own stem cells? Thank you. I think we already covered that in the beginning One thing I will say, guys, is their PRP kits are not all equal either, right? There is better PRP kits. Some will leave RBCs behind. RBCs turn into iron. That can cause apoptosis. I mean, there's other things too. So I think at some point, even if the PRP kit's just as good, an Arthrex one's what, like $300, Dr. Bell?
About that.
Arthrex, yeah, they make a kick-ass kit. Don't kid yourself. But you can get a $150 Wharton's Jelly product that's really going to rival that $300 kit. And the $300 kit is good when you've got good to pull from too. So you have the variable issue still that never leaves itself. So anyways, and Dr. Bell, I'll let you comment some more on that if you want to, because there's another question down here, but I want to go through this one real quick. I'm new to the PBIORE, the promise of success via repeat product. So basically, this person's asking about the Platinum Biologics promise, where if you don't get a satisfactory outcome, they replace the product for reapplication. It says you have to follow the protocol to the letter, or is there protocol flexibility? There is protocol flexibility. But what happens is no one at Platinum Biologics has a medical license. They don't pretend to. That's why people like Dr. Bell, Dr. Martin are available. So if you don't follow the protocol to the T, 99.9% of the time, Platinum is still going to replace the product for you, but not without a conversation with Dr. Bell or Dr. Martin because they're going to try to help you fix what happened. You can't just keep, if you have a fire, tried to put it out with something and it didn't go out, or you tried to fix something and it didn't fix it. There's no point throwing more product or money at it. We need to adjust what's going on. So sometimes you could receive more product than you even purchased if you didn't purchase enough. That's not going to happen every time. But I think that's a commitment to make sure you get the outcome. And sometimes it just needs some tweaking. So anyways, okay, now those two are out. Dr. Bell, can it help with bone on bone?
I have patients that, and again, and I hope it was illustrated in my talk here. We are obligated to give our patients good information, and we're also obligated to listen to our patients. I'm sure all of you get the patient here there that's kind of anti-surgery. And that's totally fine. I had someone today. She wasn't anti-surgery. She just did not have the time to recover. It just wasn't in the cards, personal stuff for this particular patient. So I was honest with her. I said, listen, it was a case I end up using a biologic, or I will next week for her. I said, I love these biologics for all the reasons I just said. I said, I finally have a weapon where I think I can help your problem instead of mask your condition. And I always say this with enthusiasm. And again, I go back to all the peer-to-peers I do, and I do lots of them. And that's one of the things I try to stress to my peers. Be enthusiastic. You can be because you're doing something very good for your patient. So also, and again, and be honest. And honesty is something you can't teach. If you're an inherently honest person, your patient's going to feel it. So I'm honest. In this case, I was honest with this patient. We looked at her x-ray. I said, listen, you're almost bone to bone to your question. I said, typically, I wouldn't recommend a biologic here because this looks like surgery. You have very little range of motion. You're looking at your x-ray, you have barely any visible joint space. But if you can't do surgery, hey, this is what I think is your best bet. I could inject this steroid. I'm not totally against it, but I'm afraid your bone could turn cystic. That eventually, if I have to do a replacement or a fusion, cystic bone does not hold the hardware as well. So I really don't want to do a steroid. That could maybe give temporary relief. The better option would be the biologic, this Wharton's jelly I've been telling you about. Again, we're gonna feed the joint with what it wants, so the body can have a nice secondary response. We're gonna calm down the inflammation because that's what allogeneic tissue does. It downregulates inflammation. You'll feel a little better. There's not much cartilage there for the body to help itself, but maybe there's enough, and maybe you will feel better for a while. And at the very least, I'm not damaging your joint for your likely potential replacement or fusion. And she liked the sound of that, and because it's true. And I told her this is the better option. I said, yeah, it costs some money. So if it does, I'm always respectful of that. I say, listen, it's going to cost you some money. It's not terribly expensive. I do believe it's the better option, specifically because I think eventually you need surgery anyway. And I really don't want to dump steroids to this joint because I'm going to have unhealthier bone to work with my implant, or whatever I use to do this, whether I do a fusion or I do a replacement. So I said, it's really kind of a bad idea to do steroid shots. I think She said it wasn't even a thought for the next year or two, again, based on personal reasons. So she went with it. Do I think she's going to get a knock the park out result? Probably not. She's about a 9 or 10. I like to use 1 to 10s in a lot of what I do for my notes, just for my own reference when a quick peek of a chart. But 5, 6, and 7s all day long.
I like that because sometimes, you presented it as not a solution, but you present it as part of the journey and still a better option. But sometimes I think you can be pleasantly surprised too, where it's like you present one like that, you manage the patient expectation. Because as a doctor, I always say you want to find a way to get yourself in trouble, piss off a patient, set an unreasonable expectation, lie to their face, misrepresent yourself or the outcome, and watch the storm come against your license or malpractice, right? So that's a great way to responsibly, truthfully present it. But then again, Dr. Bell, there's been some of those where you're like, I don't think anything's going to happen, but you've presented it the right way. Their expectations not baby high, but then their body just knocks it out of the park and they have a miraculous result or response, right? So leave room for
Yeah,
that happening.
I go back to redundancy, volume. So anyone in this room that's been practicing even more than 5 years, but certainly 10, 15, 20 plus years, um, when you have that kind of volume, you have a pretty good idea of what to expect. So therefore, it should be very easy to be honest. And I would think one of my recipes to success is I'm honest, and people aren't stupid. They sense authenticity and honesty, and they sense BS. They do. So honesty is critical. With that said, because I've done this for so long, and I've been using the allogeneics now for 3 or 4 years, that number is pretty high for me. So those types of conversations have happened many times because I'll have patients that are a landscaper and he can't be out of work, or I have a patient with little kids and who doesn't get, PTO for their job. And it's just they just can't afford to be out of work that long. So the cost of the biologic is nothing relative to being out of work for 3 or 4 months if they have a job that requires standing or walking. And yes, I've had plenty of patients who outperformed, I'd say. More than not, more often than not, they won't outperform if it's end stage arthritis, but I've gotten some nice results, and those are really happy people. I set a low bar not because the biologics aren't impressive. I set a lower bar if the disease state is that advanced, because that is honest. But yes, the results are so darn impressive that I am not ever shocked if I have a patient with radiographs that look pretty damn bad who is very pleased. And I probably have a bunch that still haven't gotten that fusion that I thought they would need, or that joint implant that I thought they would need 1 or 2 years out. So more often than not, they're going to need it if it's that bad. But like I said earlier, what really made sense to this patient is I told her I will probably need to operate on her, and I cannot have cystic bone. So I actually kind of refused to do another steroid shot. Not so far as to say I refused to, but I said it'll be a bad idea for me to give you steroid shots for the next year or two. I think she had at least a year or two time frame. The surgery was an absolute no-go. It was impossible for her logistically. So I said we can't be giving you steroid shots for the next year or two, because the ultimate joint replacement, the hardware will have a problem. So the biologic made perfect sense to her, and we'll see how she does. But I've had similar cases where here and there I'm like, or they come back to me 8 months later like, Doc, I'm doing pretty good. Can I get another one? You'll see, and you'll get those patients. So and you're doing the right thing, and that's the most important thing.
Awesome. We got a question, obviously with the hype of peptides. Can you combine with peptides?
So I don't want to speak to peptides, and it goes back to the theme of my whole talk. I'm a big believer in redundancy. I think most people in life aren't successful because they're the smartest or the fastest, the strongest. They're successful in whatever they do if they repeat and repeat and repeat. I see it all the time in youth sports. I see it with my son. The guys that train the hardest end up being the most successful. The guys and the gals that see the most patients are probably the best doctors. That's why I go back to policymakers. You don't treat patients, you don't have a good feel. So I don't use peptides right now. So I really don't want to, and even obviously jump in. I don't want to go there because I have a lot of knowledge about them. I do read about them a lot. I'm very interested in peptides, but I haven't used them in my practice. And what makes me comfortable doing these talks, doing these webinars, and doing all my peer-to-peers is I use Wharton's jelly almost every day. So I've used it on hundreds and hundreds of patients. I have great data, and I'm comfortable, and I can speak to all of you with firsthand knowledge that I just don't have with peptides. So even if you want to hop on that one, but I don't really want to comment yet.
Yeah, I definitely think they have a role, right? I think they're applicable. I think the feedback that we've received is that our products are kind of beyond peptides. So if a peptide's not really working, or if you're Wolverine, if you don't grow some superhero abilities and get some long samurai swords out your knuckles to cut people's heads off, and it ain't working too well, they would move up. So there might be we have some people that do. I would ask in the Facebook group. That would be a great question for the Facebook group for those that are. But my just general understanding is peptides are awesome. People love them. But I would say a lot of the people looking or seeking biologic products are probably a step beyond peptides. That doesn't mean they can't enhance. But I would ask for some more feedback from people in the group that are doing that, because it would be a little bit newer. So, anyways, to the next one. If a patient is taking antibiotics, say, uh, oh gosh, I'm gonna make me look like an idiot. Vancomycin.
Vancomycin.
Geez, yeah, all right. But yeah,
Yeah,
if there
that's
would it
okay.
decrease the potency of the stem cells?
So, as a general rule of thumb, I don't like to use them in the face of infection. Um, so I would hold off till the infection is cleared. As far as would an antibiotic interfere? Probably not. Um, I just kind of like to stay away and get my infection under control. If a biologic is pending or I wanted to use one, I just like to stay away. Mostly because I know that there's a problem. I know there's a true medical issue, but there's a couple rules of thumb I like to go by, and I would infections in this class, and it's really just a couple of situations. I would say cancer and infection. There's really no reason, and this is all the studying I've done, the reading I've done, talking with Dr. Martin. Um, I don't, and again, this I just felt intuitively, but as I've become more informed on the topic, as I've done my due diligence the last few years and spent a lot of time studying the stuff, I don't want the burden of a patient thinking an infection got worse because of a biologic, or they were in remission of their cancer and I was treating them for whatever condition I wanted to treat them for with a biologic, and their cancer came back. I don't need it. I don't want the headache. I don't want the phone call or the patient's, God forbid, is asking me, or the family member calls, such and such cancer recurred, and I want to talk to Dr. Bell and see if it had anything to do with the biologic. It does. I can't see why it does. I've paid my dues in my readings and my research. But it's just a phone call I don't want. It's a headache I don't want. And I would say the same thing about infection. Let's say an infection was improving, it was stable, especially for us in podiatry, a diabetic, and we gave a biologic for whatever reason, and we thought the infection was on its way out, and they worsened, or their white cell spiked the next day. There's no reason why it should. And I don't think the vancomycin would play a negative or positive role in any direction. I think the biologic would work just fine. You'll still get collagen differentiation with antibiotics in the system. Um, I don't think it'd be a big factor. I just wouldn't want to mess with it.
That's sometimes everyone where, doctors will ask, can I do this? And they want to mess around with some real esoteric case, and they want to, do something with limited amount of, research out there that's kind of out there, right? And I know sometimes as a physician, your best quality can sometimes be your worst, which is you really want to help people. And I see it sometimes in the Facebook group, and this is where I have to chime in and say, how many of these sick patients, how much money can you squeeze from them? And how many are you going to see to actually, I know it's about helping the person, but think about the risk to your business. How much money can you actually make doing something off the books or weird before you get sued or lose everything? And it's got to be a conscious business decision, and sometimes it's not a good business decision. So anyways, that's always a thing that I see providers get really excited about biologics, they get excited about peptides. And I always just say, hey, look, sometimes you've got to look at the entire picture, not just be a doctor. You are a business owner, and you have to switch hats sometimes, and sometimes that's really difficult with a doctor, with the passion they have and the care that they have for others. So Dr. Bell, it's a great example of sometimes strategy. It's not always a medical or clinical decision. Sometimes it's a business decision. And I think that's a great little, statement you made where it's like, hey, look, sometimes it's not worth the headache. Sometimes there's other things to consider besides clinically what's relevant. And the answer to is it going to interfere or not? No, but that's not what we need to talk about. Is it worth it, right? So, next one, what is ECM? Extracellular matrix. So ECM, extracellular matrix, is going to be with Wharton's jelly and tissue products. Exosomes and pure stem cell products do not have ECM. That's why you see like things like Wharton's jelly for local application. They're usually a far better product to choose because they have that natural scaffold. It's going to stay adherent. It's going to stay in place. Okay, we'll go to the next one. Dr. West says, I've got a 76-year-old softball teammate who has failed shoulder surgery, particular a 20 millimeter retraction on one of the rotator cuff tendons. Surgeon says not a good candidate to repeat surgery. It's been 1 year since surgery and 1 month since re-injured. He has pain and inflammation, can barely raise arm laterally now. Good candidate for biologics, question mark?
Yeah, so that's probably my favorite topic because the soft tissue pathology is off the charts, my results. So I don't treat rotator cuffs, but I treat plenty of soft tissue pathology. And anecdotally, and recommending some friends I have to go find somebody to treat rotator cuff pathology. The feedback's been great. So I have a lot of friends that will ask me, can I treat their shoulder because they know what I do, and I can't really, but so I have somebody for them. There's actually a pain management specialist near me who I did a peer-to-peer with, and now I send her patients. Soft tissue pathology, fibrosis, tendinosis, it responds so incredibly well. And I would say particularly, and again, I don't treat it, but in working with my pain management friend, who I feed her, she's pretty new in practice. She's only about 5, 6 years in. Again, I'm the one that introduced her to biologics to begin with. I've sent a bunch of people to her, and mostly it's been some hip and knee arthritis too, but mostly rotator cuff, and they've done awesome. And I'm not surprised. I absolutely love it for soft tissue pathology, and that might be a case, and maybe a peer-to-peer would be best. Not to get too detailed with this particular patient, I'm happy to answer, talk about it for 15 minutes. Maybe a case where you'd even want to use some exosomes first, and then get some structural repair going with the Wharton's jelly. But to simply answer your question, I think that patient's a great candidate.
Awesome. What's one thing to tell patients who want to try this in Mexico? How can we convince patients our products in the US are just as good or even better? Um, Dr. Bell, let me just say this first because I think some people don't realize this, but if you look up Florida has a stem cell bill, Texas has a stem cell bill, and right to try. Utah has a stem cell bill, and now Tennessee has a stem cell bill. So the fact you need to travel to Mexico is not even accurate. And the problem with policy and legal stuff is, it takes a while for information to even travel, right? And if you look at even historical events, we have a newer, event, even look at Juneteenth, right? This is a newer holiday that people are celebrating. My country club we're going to take the kids to the pool. It's a celebration. Time for information to travel takes time. And these people are behind the ball thinking that there's some type of magical fix that some doctor who didn't get licensed in America is going to make your stem cells in the jungle. And that is just not really a kind of a good thing there. And I can tell you that from a manufacturing sales perspective, because Platinum Biologics actually distributes to 4 different companies out in the Caribbean, Mexico, Ecuador, and South America. Why? Because instead of telling them that their licensed doctor who wasn't trained in America, who now you have an American that flew there, is uncomfortable about the doctor, they don't sound like they speak, American English, right? And nerves start to change a little bit. This is hard when people show. A lot of people leave and don't go through the treatment too and want money back. They'll even lose deposits and stuff. You'd be surprised because we hear these complaints from these destination and tourism clinics. What happens is it's much easier for them to say, oh, we actually source this from Platinum Biologics in the United States, and this is American made product where they can't make it as strong. You want to know the real answer to that? It's not true. It sounds good when you have someone else in another country, though. So The answer is that that's old information. Culture and expansion of stem cells, there are stem cell bills actually allowing that. But also, I want to point out too, is that, and Dr. Bell, we're going to answer one more question too, because I'm going to tee you up for this, is that Wharton's jelly is local application the best because of the tissue complex of it, right? The scaffold, the local adherence, Wharton's jelly. No one really argues that. Once you look at the data, everything else, and Dr. Bell will back me up on that. What do you think the chances are? If you're using Wharton's jelly, this should be a slam dunk for you to answer this question because how many in a third world country or destination clinics, how many complete medical records are these people getting for proper donor screening? These people don't even have real banks. They have corrupt banking systems. They have cops that are on the pay. And you really think they have a medical system that is trustworthy enough that you're not going to get infected with some disease or something like that by tissue collection? They don't have full medical reports a lot of the time in these hospital systems. So what Mexico and these other places don't have, they have stem cells, they can culture stem cells, but they don't have tissue products because they don't have consistent flow of qualified donor screening systems. So really they can only compete on one aspect of the biologics industry, which is concentrated, replicated cellular and exosome products. But Dr. Bell, what is the number one product you use in your office? And what do you use them for most typically? We're going to hit out 2 or 3 questions in one here.
Sure. So, yeah, I mean, Wharton's jelly is it's structure and elasticity, especially if we're talking soft tissue, but cartilage too. And what you're getting out of Wharton's jelly, the key again, you're getting collagen that after age 30 we don't make anymore. So if a 53-year-old has a rotator cuff tear, he's not producing a whole lot of collagen at that age. It's just not happening. But you apply Wharton's jelly to the area, you're giving the rotator cuff, or you're giving, in our world, say the Achilles tendon, you're giving it types 1, 3 collagen, a little bit of type 2 collagen. You're giving it extracellular matrix. You're giving it hyaluronic acid. That combination calms down the joint, provides a healthier, for example, when we cut into an inflamed joint where there's pathology or an inflamed, partially torn tendon, what do we see? We see yellow fluid. It's nasty chronic inflammatory fluid. So everyone who's a surgeon out there knows when you cut into an old arthritic joint or an 18-month-old tendinous tissue that's been a problem for a year and a half, and they've gone through PT and cam boots, and it's a joke because there's no PT or boot that's going to change a hypertrophic Achilles tendon. And I think the rotator cuff would be a similar kind of an analogy. When we operate on those patients, I see, instead of yellowish fluid, it's like yellow orangey fluid, bad tissue. The body cannot repair itself in that state. That goes back to my explanation to my patients, how I make them get on board with this, make them understand, and make them as enthusiastic as I am. We're going to change the environment. When I apply the Wharton's jelly, everything that it has in it, the differential mesenchymal stem cells, the hyaluronic acid, the collagen, the hyaluronic acid, the abundance of all that, it's going to down-regulate inflammation. Number one thing. So you have a healthier environment, and it's going to, by putting all those cells in there and those growth factors in there, after the inflammation is going to calm down, it's going to allow for collagenate differentiation for the body to start to produce what it hasn't been producing. And if you don't get the right tissue, you're not getting that secondary process. So it doesn't come up a whole lot because I think my patients just trust me. So sometimes I just bring it up because I like to, because it's fun, or if they do ask, they're certainly entitled. And I kid with them like, it's amazing the trust you have to have in your doctor. I could walk out and I'll kid with my patient sometimes. I could put water in the syringe and inject you. I mean, it'd be disgusting and criminal, but no one would more than likely know. I got to think at that same level where I get my product from. I have a responsibility. There may not be a profession on earth that's where there's so much responsibility placed in your hand if you're taking care of someone else's health, and they have no clue really what you're doing. So where I get my product from is everything. I don't really know what's in that vial. I don't have machinery or compute to tell me. I have to trust the company that I do my research on. They're scientific, and they're ethical, and they're informed, and they're on top of everything. They got to be on their game for me to buy their product because I'm putting their product into my patient. And if you have even an ounce of moral code, you ought to know what the heck you're putting in your patient. I
Oh,
lose you,
thanks,
B?
Doctor. No, thanks, Dr. Bell. I had a moment with my mute button. Um, Let me see here. There was a good question. It was a specific one. And I know you like those specific ones. Have you dealt with patients with small Achilles enthosophyte? Am I saying that right?
Yeah, you hear it close and stop the.
If,
Yes, so I
if
have.
if so, what treatment approaches have you found most effective and what outcomes have you seen?
Sure. So if the bone proliferation is extensive, it's probably going to be surgery. But if it's smaller, I explained to them your Achilles has probably been inflamed for quite a long time. Inflamed tendons hypercontract. Hypercontracted tendons function tighter. If an Achilles tendon functions tighter, it pulls the back of the heel bone with more force than it should per step. Bone is very dynamic. It responds to that little extra tension from the Achilles, and it eventually builds more bone. So first thing I'll explain to them, the root of the problem is your Achilles. Your Achilles has to be tight. Spurs don't form out of nowhere. In this case, the back of the heel bone, a posterior heel spur, forms because the Achilles is too tight. Again, why is the Achilles too tight? More often than not, because it's been inflamed for a long time. Inflamed tendons tissue hypercontracts and becomes tighter. Now, some people just are inherently tight, and that's a different story. But in a case where I feel like they've probably had chronic intermittent tendonitis because they play racquetball or they run for the last 5 years, I will tell them I'll usually do an MRI. And if there's some hypertrophy in the tendon, or if it's palpable, I don't always do an MRI. I like to give choices. I tell my patient, I'm confident your tendon's hypertrophic. I explain to them it became thick because it's been inflamed forever. And I go back to this is what makes people get it. I say your body, this is not an injury. Your Achilles tendon did not become hypertrophic and tight yesterday or 10 days ago. It's become tight because it's been inflamed off and on for the last 5 years because you play tennis 3 times a week, and that's great. But unfortunately, as you're not 22 anymore, when you play tennis 3 times a week, you're probably going to aggravate your tendinous tissue, and the Achilles is one of them that's very prone to it. So your Achilles bothers you off and on for a couple of years. Tells me it's probably been inflamed off and on for a couple of years. It gets inflamed, it becomes tight, it pulls too hard, and now you got that spur. So we can attack the root of the problem by addressing your Achilles. And I very often use biologics here. And what I explain to them is if the whole process, the collagen differentiation, I don't want to keep repeating it. If we can calm down the inflammation, if we can feed or supplement the Achilles tendon, if we can make the body allow for that environment to help bring along collageneric proteins, then the Achilles tendon can become a healthier tendon because we're going to create a secondary inherent process with the use of Wharton's jelly. The integrity of the tendon in many cases will improve. If you did a histopathology exam on it, pre and post, there'd be some differences. You would have less fibrosis and such, and you could regain some elasticity. And the tension would and a good outcome would decrease. And then the spur will become, in some cases, negligible because it wasn't really the spur that was hurting you. It was the tension on the spur. So I do get good outcomes in many cases, but I always will explain to them the spur. If the spur hasn't formed yet, I really love using biologics because I'll beat it. I won't let the spur form. If it's somewhat large, I will tell them, look, you have a somewhat large spur. Hopefully we can help take away that tension by making your Achilles tendon a healthier structure by this process. But the physical spur itself is rather large. Sometimes that's just got to be taken out. But again, and I say this every time, as you all know who are surgeons out there, long recovery. You got to peel back, and I explain it. You got to peel back the Achilles. You got to get to the spur. You have to resect it. You have to reattach your Achilles. That can be 4 to 6 months. So I tell a lot of patients, I don't know if the spur is really so much the source of your pain or your tendon is, but if it's mostly the tendon, and we can make the tendon better by applying the Wharton's jelly, you could get a great result and be thrilled and avoid the surgery. But if you don't feel much better, it might very well be that physical large spur that's hurting you. So I just can't ever know for sure, especially if it's rather large. If it's small, I'm very comfortable going non-surgical. In fact, I'll always try to go that way. It's rather large. I just, again, honest, and I say, hey, this is a pretty darn big spur. It's rubbing against the back of your sneaker, the inside of your sneaker every step you take. no matter how much healthier we can, this Wharton's jelly can make your Achilles. The physical sport itself might just always be a problem. So please realize that, and then I make them. Then they make their informed decision.
Nice. One, what this is a good one here. Let me do this one. What applications, if ever, do you add exosomes to the injection? And then, Dr. Bell, I'm gonna do a part two. Is there any time or time you would consider maybe adding exosomes, maybe not even to the injection, but as a standalone or in combination of the total protocol? How do you differentiate exosomes or Wharton's jelly, or how do you use them together, or even independently, or systematically in a protocol, I guess?
So there's a lot to unpack there, Beeb. I'm sure you can jump into. So I do, and I don't like to steal from other people, but Dr. Martin's darn good, so I'm going to steal this one from him, and it's accurate. He said this, he coined this, I think, and I love it. I use it with my patients. Exosomes will put out a fire to allow the Wharton's jelly or the secondary inherent structural pair to do a better job. So if I have a nasty case of any of the pathologies we've kind of talked about tonight, let's say again, for if this is mostly podiatrists out there, I'll use chronic posterior tibial tendinopathy. I love using exosomes first. I play with both as far as mix them together, the exosomes and Wharton's jelly, and because I talked to so many docs, so I like to experiment a little bit. So I can, if a doc asks me which is better, put them together, do them separately. I kind of played around with that. In the end, I don't find much of a difference, but I stick to my own little thing here. But I don't think in my own experiment, I haven't seen much of a difference. I will do the exosomes first because, say, a posterior tibial tendinopathy, for every podiatrist out there, we know that that's a pretty nasty deformity, right? That tendon is really worn down. It's tethered, it's frayed. They're terribly inflamed. They're usually visually edematous. There's a fire. So there you can, and I tell patients, I say, listen, this is a case where I don't want to see you have to spend too much money, but you have a lot of pathology. I really want to help you. I hate doing posterior tibial tendon repairs for unhealthy tendons because, again, super long recovery, and we're obligated to provide high standard of care. When a non-surgical option exists that I think is attractive, I have to mention it. It's my job. So I say, in this case, and I'll tell the patient, I don't usually use what I'm about to tell you. And I say, I would like to use exosomes. I'll tell them what exosomes are. And I'll say, basically, it's to calm things down. So then we want to give back that structural support. It's in that much of a better environment. So it's a two-step process for you, Mrs. Smith, because you have so much damage. And I will tell the patients often when I bring this up, I usually don't go there. I usually don't need exosomes in what I personally treat because the Wharton's jelly alone does a great job. And I don't want to see you have to spend, that much more money. But I always say, like, comma, pause. It's not that much money. It's not terrible relative to a 4-month recovery. So Mrs. Smith, you have so much inflammation and pathology. I got to calm that environment down to really then help out the structural repair that I hope your body provides after we hit it with the Wharton's jelly. So that would be like a specific case where, and I generally do exosomes in that case, maybe day one, and I'll do the Wharton's jelly 7-10 days later. Do I see similar results? Mix them together all in one moment? I don't see much difference. I just like doing them separately.
I think what we found is exosomes, especially when you're primarily in the field of podiatry, you're not doing what I like to say weird stuff because you can't. It's like outside your scope of practice a lot of the time, right? Or it's questionable, or you just you're not going to deal with as much esoteric type stuff. But I think the exosomes are a great sacrificial layer. You don't want to burn up your biologic with someone who's not in a position or the environment to actually get their money's worth, right? And I think that's what Dr. Bell went over. I think there were some trends we found. People were doing neuropraxic cases, peripheral neuropathy, right? And people get great results with that. They get great results with that. Then just bang, zero result with one patient. And it's a lupus patient. They have lupus neuropathy. That's something where if the lupus is out of control, you're probably going to burn up lots of Wharton's jelly. That would probably be, I know that's been brought up on the times before. There is a couple of videos on when to use the other, but I would say, like Dr. Bell had said, the feedback we've received is being a sacrificial thing, especially for the lower cost exosomes. That seems to be a really great application in front of the Wharton's jelly is kind of a sacrificial thing. Get that inflammation out so the product and the body can actually do what they need to do. Okay, so that takes care of that question. And then, Dr. Bell, how much are you charging for Wharton Shelley?
I charge $700. I would say, again, I do a lot of peer-to-peer chats, and a lot of docs will get back to me, and we maintain a little bit of relationship I maintain sometimes a relationship with them. They'll text me because I will get that question a lot. It's a fair question. Look, it's a free country, it's a free market. You charge whatever the heck you want. Obviously, you want a price point where you're not going to outprice people. Everyone practices in different demographics, so it's pretty hard to kind of sometimes to say, well, what should I charge? And I think some docs and feel awkward because we're not used to that. We're used to that third party payer, which I can't stress enough. Who cares? It's okay. It's a free country. You're a great doctor. You can practice medicine. You can also get paid reasonably. So go for it. So that's what I do. I would say that's average. And the docs I talk to start becoming users and they get back to me. I'll hear the low end, 450, the high end. And this is with the more common Wharton jelly product we call nano DPM. It's a pretty go-to product for the lower extremity. The low end 450, the high end 11, 1200, probably 800's a good middle number, 900.
Perfect. And guys, Nano DPM is an entry level product cost factor. There's also Nano Jelly, which is only $150. And that's if you're going to charge per injection. A lot of physicians, they kind of get their confidence level up, right? And they'll charge per injection. Some people get a bit more aggressive, right? And they'll say, hey, look, I know what's going on. I know I can get you results. I want to do a $3,500 case. You're going to get 3 applications. We're going to add the MLS laser in there, and they begin to call what's called packaging protocols, right? And I have some big groups out in California. We've got a 150-man podiatry group. They buy hundreds a month, and they just throw it into their surgeries. I say you can defensively use this, you can use it as an option, or you can get more aggressive and it can fit the way you want to practice medicine, the style, the way you want to charge, or the way you want to couple it, package it. That's a loaded question. But we have some other videos and recordings on that if you do want to get up to the higher ticket type stuff and know what's going on out there. But Dr. Bell's spot on the money. If you're going to charge, the easiest way is start charging per injection, and then you can begin to get more creative with it for sure.
Yeah, that's
Okay.
very common. And that's that when I kind of start to guide my colleagues, they'll say, well, what do you think about combining it with a laser um, or other modalities? I say, yeah. And I say, what I do when I do that, I package it and I may lower the cost of both, but overall I make more because I'm going to do a combo. Because again, if I feel like it needs a lot of kick, if there's enough pathology there, um, what I tell the patient is we have a great new ways to help this problem that was historically almost not even treatable or by aggressive surgeries or even the surgical outcomes weren't so great. And I think you need A and B, hypothetically. I package them both, and like I said, maybe I'll charge a little less for each, but overall we make more because I'm doing both. Generally speaking, in my practice, I stick mostly with the biologics, but I do some laser therapy as well. The MLS, I do think it's as an adjunct can be kind of can be effective.
Awesome. Dr. Bell, is only one application enough?
Yes, that's very, it's super fair question. I get it all the time, but it's obviously quite broad. So it really depends on not only the diagnosis is, but the severity of the diagnosis. I think Platinum's developed really great protocols. Platinum, I love them because they do their due diligence. Um, I don't get too protocol driven in my chats with the patient because I don't want to spook them. So if I think they're going to need a few rounds, I'm never going to say it, but I don't make it like black and white. This is definitely what you need because people are different. They respond different. To answer that question though, in a general sense, Um, Many things that we treat, and I'll say podiatry and ortho, one is enough. Let's say stubborn tendonitis, whatever tendon you want in the body you want to talk about. Well, if you catch the body part, if you catch the soft tissue before it's significantly fibrosed or hypertrophic, that tissue can return to normal health. And again, if you plucked and did a histobiological, did a histology exam on it, and you would see healthy tendinous tissue versus inflamed tendinous tissue. So one can be enough if it's just like say 7 or 8 week old Achilles tendonitis, and I do it for this. If it's 7 or 8 week old Achilles tendonitis, I'm probably going to mention more traditional cares, but I'm going to talk about biologics for 3 minutes as well. And the bulk of them will maybe stick with the traditional option because I'll say a traditional option isn't a terrible idea because you're coming in pretty early on. You're only 6 weeks symptomatic. I don't have too much pathology to deal with. Maybe even a month of Advil is good enough to just calm things down. But we want to go a more advanced way here, in my opinion. So one can be enough for, let's just call it not mild pathology, mild tendonitis, let's say mild neuropathy. Sometimes I'm still on. Again, I have great data in my practice. I have a whole bunch of patients are still on round one for neuropraxia, whole bunch. But that I always talk about because let's say it's diabetes induced, and we're getting off topic, but who cares? Let's say it's diabetes induced. You can apply a biologic to a degenerative nerve tissue, sensory nerve tissue, and you can help again by that secondary response. You can help the epineurium build back up, and when the epineurium builds back up, the nerve signals are more appropriate again, and the paresthesias are gone. The burning, the tingling is gone because it's a proper current because it's a healthy cell wall because we've helped restructure that cell wall. But you're still a diabetic. You still have too much glucose in your system, which eventually, if you stay high with your diabetes, if you don't control it better, it's going to turn into sorbitol. Sorbitol is an alcohol. Alcohol is going to degenerate the cell wall, and therefore you can go back to neuropathy. So I tell them this can help you a lot, but if you have a hemoglobin A1C of 8.5 continuously, you're going to get, so to speak, neuropathy again. So again, that's why it's hard to answer the question because everyone's different. I could have someone with a hemoglobin A1C of 5.8, 6.1, mild paresthesias, give them one round of Wharton's jelly. I'm sure I have plenty of those that are still thrilled 3 years later. But if I have a diabetic who's obese, and I know they're not well controlled, and sometimes it's not their fault. Forget them being obese. Some people eat as best they can, and their body just produces too much glucose, and they go all day long with their endocrinologist, and there are all kinds of medicine combinations of metformin and insulin and all the new stuff, the glyburide, and it's not their fault sometimes, and they still function at 7.9 A1C. They're going to get really good relief more often than not, but I can't say it's going to be forever because they're still diabetic. So, patient specific, pathology specific.
Awesome. Okay, last question of the night, and guys, we will reach out that you know, we have some more questions and stuff, so we'll try to get to these and answer them for you. The peer-to-peer has no cost. I just saw that one come in. There's a link in the chat. You can also go to podiatrypracticeprogram.com and the calendar is there. None of the peer-to-peers cost anything. And make sure you join the Facebook group because then you can talk with your peers and people that are, I've been talking with Dr. Bell for over a year, 2 years, and they've seen improvement through his guidance and their practice has expanded and blown up. So, all right, Dr. Bell, last question. Do you inject right into the damaged or weak area like the Achilles tendon or flooding the area? What's your response on that?
So in Achilles specifically, because it's a fiber structure, it's going to kind of pour back out, so to speak. So I kind of like the way the question was worded. I like to flood the area. Look, the great thing is what you're getting in Wharton's jelly causes such a nice secondary response. It causes that inherent secondary response, that collagenate differentiation, which is ultimately the key. That's really what we're doing. It's collagenate differentiation. So the body starts doing what it can do. You're just giving it the fuel. So you don't have to be like in point accurate, which is pretty cool. Because a lot of questions I'll get when I do my peer-to-peers again is, how accurate do I have to be? Do I have to do it ultrasound guided? And my answer to ultrasound guided is never bad or wrong. It probably looks pretty cool. If you have an ultrasound, great. Why not use it? patient maybe thinks they're getting more bang for their buck. I don't think it's necessary in our world, in the extremities world, whether it's upper or lower, because we know our anatomy pretty well. It's not real complex to get in and around the tendon or in and around the joint. So for a tendon, I would say flood the area is the way I'd go about it. A direct application, if you plunge it into a tendon, it's so fibrous, it'll come back out more than likely anyway, and you don't really have to go in the tendon, and it's a little more painful. And you don't want to use lidocaine. So I'm glad I got a chance to say that. Don't do a local nerve block. It's toxic to the differentiated mesenchymal stem cells. So you just got to give it, but it's not viscous. You can use a 25 gauge needle and flood the area.
Perfect. Okay, I know we have a couple of essential questions, everybody, but we're at an hour and a half, and I know they'll just keep coming in. The protocol and injection sites, there is a protocol in the back office, and you can always throw that up in the group as well. But guys, check the chat before we head out here. Please look at the chat. You'll see the peer-to-peer. You can have your own peer-to-peer direct with Dr. Bell. There's also a link to the Facebook group. Any of you that had some more product-related questions, this is the IORE with Dr. Bell. We're really trying to stay more clinical, but obviously we try to go through as much as we can with you guys. But for any of those more product-related questions that didn't get answered, make sure that you reach out in the Facebook group, or you can reach out to Platinum or the IORE as well. But everyone, that concludes tonight. We want to thank you guys for everything. This will be posted in the IORE in the recording section. If you haven't been in there, there's over 500 hours now. We did just get the payment up gateway up, so it'll be official. You can register into the IRB retrospective repository and be practicing experimental use of biologics underneath an FDA accredited HHS serialized protocol, which gives you unique individual protections, but also you can track the safety and outcome of your patients. And Dr. Bell and Dr. Martin will actually be reviewing that statistically significant data and publishing papers with your name on it. So super, super cool. It's not a manufacturer sponsored study like all the other manufacturers and companies. They do it for themselves. They do it to get some magical approval to hope insurance covers it, which is a pipe dream. It's really just to pipe up their own product or company. This is for doctors by doctors, so we invite you guys to join. With that, thank you for tonight. Thank you, Dr. Bell. Thank you for your time, your wisdom, and continued success out there with the patients. That's it. If you want to say goodbye to everyone, then we'll hop off.
That's where to end it.
All right, everybody.
All
Bye-bye.
right.
Have a great night.
Good night, everybody.